Welcome to a deep dive tailored just for you. Today we're tackling a specific set of revision notes, really zeroing in on a common and important clinical problem, arterial ulcers.
That's right. We're going to, break down this stack of notes and turn it into a really high-yield summary of everything you need to know about these ulcers, focusing just on the material provided here. Perfect for revision.
Our mission really is to pull out the absolute key nuggets, the definitions, the causes, how they present, the tests, the management, making it all clear and hopefully memorable. Think of it as your shortcut to getting up to speed quickly.
Exactly. We'll cover the definition, the etiology, those risk factors, the pathophysiology, how it happens, the differentials, so what else it could be, the epidemiology.
He gets them.
Right, the clinical presentation, investigations, management, and then prognosis and complications. And we'll definitely flag those memory tips from the notes, too.
Okay, let's unpack this then, starting right at the beginning. What exactly are these arterial ulcers the notes are talking about?
So basically, they're chronic wounds. You usually find them on the lower legs or feet. And the core issue, as the notes really stress, is inadequate blood supply.
Ischemic ulcers, they call them.
Precisely. Ischemic because they result from, well, insufficient tissue perfusion. Not enough oxygen, not enough nutrients getting to the tissues because the blood flow is reduced. And that's very often linked back to atherosclerosis in peripheral arterial disease, PAD.
And the notes are pretty clear about the stakes here. If these aren't treated properly, infection, gangrene, tissue necrosis, potentially even amputation, it really tells you how serious this is.
Absolutely vital to recognize. Which leads us to why this happens, what causes this poor blood flow. The notes point squarely at impaired arterial circulation.
So PAD and atherosclerosis are the big ones.
Top of the list. But the notes also mention that other things can contribute, like conditions that reduce tissue oxygenation, overall severe diabetes, for instance, or heart failure. They can also lead to this kind of tissue ischemia and ulcer formation.
Okay, so that brings us to the risk factors. This is really key for spotting who might be vulnerable, isn't it? The notes give a pretty clear list.
Yes, a very clear profile. It's the classic list for poor vascular health, really. Smoking is huge, hypertension, high blood pressure.
Coronary heart disease, high cholesterol.
Hyperlipidaemia, yeah.
Yeah.
A history of stroke or TIA. Diabetes mellitus is a major one.
And already having PAD may be showing up as that claudication pain.
Right, that intermittent claudication, the leg pain on exertion that eases with rest. The notes flag that as a key symptom. Plus, they add obesity, immobility, just older age generally, and a family history of vascular problems.
Seeing all those together, it really shows how this isn't just a leg problem, is it? It's systemic.
Absolutely. It's a window into the patient's overall vascular health. These are the same risk factors for heart attacks and strokes,
So the pathophysiology, how does that lack of blood flow actually cause the ulcer? Can we break that down simply?
Yeah, the notes keep it quite concise. Basically, reduced arterial blood flow means the tissue, especially down in the feet and toes, just doesn't get enough oxygen and nutrients. That's the ischemia.
And that affects healing.
Massively.
Yeah.
It impairs the tissue's ability to repair itself. So any minor injury, maybe pressure from a shoe or just normal wear and tear, that healthy tissue would handle fine. It just can't heal. The building blocks aren't arriving. That leads to tissue breakdown and this chronic non-healing wound.
Okay, this is crucial then. You see a leg ulcer. How do you know it's this kind, an arterial one and not something else? The notes list the differentials we need to think about. What are the main lookalikes?
Well, top of the list, and way more common actually, are venous ulcers. They look quite different usually. Then you've got diabetic ulcers, which can be complex, sometimes mixed, and pressure ulcers, especially, say, on the heel in someone who's not very mobile.
But the notes push us to think a bit wider, too.
They do. They remind us about ulcers linked to inflammatory conditions like rheumatoid arthritis or other systemic vasculitides. Hypertensive ulcers, too, from really severe high blood pressure. Even malignant ulcers, where a skin cancer presents as a non-healing wound.
And some metabolic things.
Yeah, and ulcers related to metabolic or hematological diseases. It's important to keep that broader list in mind so you don't miss less common causes.
So how common are these arterial ones, relatively speaking? The notes give UK data.
Yeah, they state arterial ulcers make up only about 2% of all leg ulcers. Venous are the vast majority, around 70%, and then maybe 15% are mixed arterial and venous. So while they're less frequent than venous ulcers, they are a distinct and significant group.
And need very different management, as we'll get to.
Critically different, yes.
Which brings us to the clinical presentation. What do these ulcers actually look like? What are the signs?
The notes paint a clear picture. Typical locations are pressure points, the lateral malleolus, the outer ankle bone, the heel,
Hmm.
sometimes between the toes from shoe pressure.
And the appearance.
They often look quite punched out, like someone took a hole punch to the skin. They tend to have symmetrical, very well-defined, sharp borders, not ragged like venous ulcers often are. And the base, the wound gut itself, is frequently necrotic, black, dead tissue.
What about the skin around the ulcer?
Often looks quite thin, maybe shiny, atrophic. You might notice hair loss on the lower leg and foot.
Hmm.
And a really key sign the notes highlight, the pulses in the foot, like the dorsalis pedis on top or the posterior tibial behind the ankle, they're often absent or really weak, and the foot itself feels cold to the touch.
Okay, signs are one thing. What about symptoms? What does the patient report? Pain must be a big feature.
Oh, absolutely. Pain is usually significant, often described as a burning sensation. And a classic feature is that it gets worse at night or when the legs are elevated in bed.
That's counterintuitive almost.
It is, but it's because gravity isn't helping pull the already limited blood supply down to the foot when it's raised. Then there's intermittent claudication, that cramping pain on walking we mentioned, indicating the underlying PAD, and in severe cases, you get pain even at rest.
The notes mention a specific syndrome too, Loricia's.
Yes, Loricia's syndrome.
Yeah.
That's claudication pain specifically in the buttocks or thighs, combined with absent pulses in the groin, the femoral pulses, and often erectile dysfunction in men. It signals a blockage much higher up in the iliac arteries.
Now, the notes give us a fantastic memory aid here for peripheral vascular disease in general, the 6Ps. This seems really useful.
Absolutely essential mnemonic. The notes list them clearly. Painful, often severe. Pallor of the limb looks pale, especially if you lift it up. Pulseless or reduced pulses, obviously. Paresthesia, that's numbness or tingling, suggesting nerve involvement. Paralysis less common, but possible with severe nerve muscle ischemia. And poikilothermia, meaning the limb feels perishingly cold.
Perishingly cold. I like that.
It sticks in your mind. The 6Ps are a great rapid check if you suspect acute or critical limb ischemia.
The notes also remind us to do a full assessment during the exam, not just look at the hole.
Yes, definitely. Measure the ulcer size, track it over time. Note the edge and base characteristics. Check the surrounding skin carefully for any signs of infection, redness, warmth, discharge. And then the full vascular assessment. Feel for pulses on both sides. Check sensation. Look for varicose veins or swelling edema or skin changes like eczema, which might point more towards a venous issue, actually.
And basic obs.
Yeah, record pulse rate, blood pressure, and calculate the BMI. All part of the picture.
So summing up those red flags from the notes that really scream arterial ulcer, no
Ye-
pulses you can feel, pale or bluish skin, that thin, shiny look, hair loss, thick nails, the punched-out ulcer itself, and that horrible pain, especially worse at night or on walking.
Exactly. Those are the key features highlighted.
Right, so we suspect it. How do we confirm it? What investigations do the notes recommend?
Well, they start with some simple bedside things. Capillary refill time, press on a toe. See how quickly the pink color comes back? More than 2 seconds is slow, suggestive.
And the Berger test.
Yes, Berger's test. You lift the patient's leg up high for a minute or two until it goes pale, then quickly hang it down over the side of the bed. You're looking for how long it takes the normal color to return. If it takes more than, say, 10-15 seconds, that suggests significant arterial insufficiency.
Simple checks. But the main investigation mentioned, the one that seems really critical in the notes, is the ABPI, ankle brachial pulse index.
Absolutely fundamental. This is the key diagnostic test according to these notes. You use a Doppler probe to measure the systolic blood pressure in the arteries at the ankle and compare it to the systolic pressure in the arm, the brachial artery. The ratio gives you the ABPI.
And the notes give specific numbers we need to know.
Yes, these cutoffs are crucial. An ABPI less than 0.9 suggests PAD is present.
Okay.
If it drops below 0.5, that's a serious sign. It indicates critical limb ischemia. The limb is genuinely at risk.
Right, that's the urgent referral category.
Exactly. And an ABPI below 0.3 is strongly associated with actual ulceration and gangrene having already occurred. Very poor perfusion.
But there's a catch with high numbers.
Yes, watch out for this.
Yeah.
An ABPI above about 1.2 or 1.3 can be falsely reassuring. It might mean the arteries are heavily calcified, very stiff, so you can't compress them properly with the cuff. This happens a lot in patients with long-standing diabetes, so a high reading doesn't rule out PAD in those cases.
Good point. What other tests do the notes suggest looking into?
They mentioned thinking about underlying causes and potential complications. So a urine dipstick for glucose, could they have undiagnosed diabetes? Swabs from the ulcer if it looks infected to guide antibiotic choice. An ECG to check the heart rhythm, looking for things like AFib.
And blood tests.
A full blood count, HbA1c for diabetes control over the last few months, lipid profile for cholesterol, ESR maybe for inflammation, UNE's kidney function important before starting some meds, and possibly autoantibodies if you're thinking about vasculitis, like checking rheumatoid factor or ANA in the context of RA or SLE.
What about imaging? Seeing the actual blood vessels.
Duplex ultrasound is listed as the first-line imaging. It uses ultrasound to visualize the arteries and blood flow, looking for narrowings or blockages. MRA, magnetic resonance angiography, is mentioned as second line, and the notes say it could be particularly useful for assessing tissue viability, maybe helping plan surgery.
Biopsy.
Only if you suspect the ulcer itself might be malignant, like a squamous cell carcinoma developing in a chronic wound. Then a biopsy is needed.
Okay, going back to the ABPI for a sec because it seems so central, the notes stress its interpretation again.
They really do. That ABPI less than 0.5 means critical ischemia, suggests arterial cause, and vitally it means compression therapy is contraindicated. You absolutely must not compress that leg.
That's a safety critical point.
Definitely. And they repeat the caution about ABPI 1.3 possibly being calcification, and also remind us that ABPI measures flow of the big vessels. It doesn't really assess the microvascular circulation, the tiny vessels, which can be a big issue in diabetes too.
The notes also give quite specific pointers on when you need to refer the patient on.
Yes, it's a helpful list. Refer if you're just not sure about the diagnosis or if the ulcer is getting worse quickly or just looks odd, atypical. Specific ABPI results trigger referral, generally if it's 0.8, urgently is 0.5, and also refer if it's 1.3 because of the calcification issue.
Other reasons.
Suspected malignancy needs referral. Comorbidities like sending a diabetic patient to a specialist multidisciplinary foot or ulcer clinic, or someone with suspected vasculitis to rheumatology. Also, poor mobility impacting healing, suspected blockages higher up, any complications, venous ulcers that just aren't healing despite good compression, or recurrent ulcers. Basically, if it's complex or not straightforward, get specialist help.
Makes sense. So let's talk management. We've diagnosed it, assessed the severity. How do we treat these arterial ulcers according to the notes?
The core principles are, number one, treat the underlying vascular disease. You have to improve the blood flow if possible. Number two, manage the wound itself, debridement, keeping it clean, managing infection. Number three, pain control is vital. And number four, using both pharmacological, drug treatments and non-pharmacological approaches.
And the big, don't we keep mentioning?
Cannot say it enough. Compression therapy is contraindicated. The notes are emphatic. It will make things worse.
Okay, so apart from not compressing, what are the non-drug or procedural options?
Well, wound management involves choosing appropriate dressings, often ones that keep the wound moist but don't stick, and debridement, removing that dead necrotic tissue to allow healthy tissue to hopefully grow. Antibiotics only if clinically infected. Interestingly, yes. The notes list supervised exercise training as first-line management for patients with intermittent claudication. It can help develop collateral blood vessels, little bypass routes around the blockages.
What about fixing the plumbing?
Revascularization is key, if possible. That means procedures to restore blood flow. The notes mention angioplasty, using balloons or stents to open up narrowed arteries, or bypass surgery, grafting a vessel, often the patient's own vein taken from elsewhere to go around the blockage.
And worst case?
Amputation is mentioned as the last resort if the limb just isn't salvageable. Skin grafts or flaps are sometimes used for wound closure, but the notes caution their success depends heavily on having adequate blood supply restored first.
Right. Now, what about medications? What do the notes suggest prescribing?
Okay, several categories here. For the PAD symptoms, the claudication, vasodilators are mentioned. Naftidrofuryl oxalate is listed as first line for claudication. Siltazol is another one, but noted as having limited use.
Pain relief.
Crucial, especially in critical limb ischemia. Paracetamol might be enough for mild pain, but often opiates are needed for severe rest pain.
And tackling the underlying risk factors.
Yes. Lipid-lowering drugs, atorvastatin typically, aiming for specific cholesterol targets. Antihypertensives to control blood pressure, ACE inhibitors are mentioned, but with that caution about renal artery stenosis. Beta blockers also listed. Good diabetic control if the patient has diabetes. And, critically, antiplatelet therapy to stop clots forming. Clopidogrel is listed as the first-line choice for PAD in these notes.
And just general health advice.
Yep, the notes rounded off with the importance of good nutrition support healing, good foot hygiene to prevent secondary problems, and absolutely fundamental, smoking cessation. Stopping smoking is probably the single most important lifestyle change.
Okay, finally then, what's the outlook, the prognosis for these ulcers, and what complications should we be aware of?
The prognosis, the notes suggest, is often quite challenging because the root cause is poor blood supply. Healing can be slow, difficult, and recurrence is common. The outcome really depends on how severe the PAD is, the ulcer size and duration, the patient's overall health, other conditions they have.
Are there factors that suggest a worse outcome?
Yes, the notes mention adverse indicators like the ulcer having been there a long time, being very large, the patient perhaps struggling with compliance with treatment, and potentially lower socioeconomic status being linked to poorer outcomes too.
And the potential problems, the complications that can arise.
Immediate risks are infection spreading from the ulcer cellulitis. If the ischemia is bad or gets worse, gangrene, which is tissue death, worsening limb ischemia overall. And as we said, amputation if things can't be turned around.
But also wider effects.
Yes. The notes mention chronic pain significantly impacting quality of life, immobility resulting from the pain or the wound itself. Psychological distress is common, and just major restrictions on daily activities. Plus, that open wound is a constant risk for bacterial infection getting into the system. Sepsis and the nerve damage from ischemia can cause persistent numbness, tingling, or even weakness, paresthesia, or paralysis.
Wow. Okay, we've certainly covered a lot of ground there, working through those revision notes on arterial ulcers, from the basic definition right through to the potential complications.
Yeah, by breaking down the causes, the risks, how they look, those key investigations, especially remembering those ABPI numbers and the 6Ps and the management do's and absolute don'ts like compression. Hopefully we've structured it in a high-yield way for revision.
I think what stands out most, for me anyway, is how the seemingly localized problem, the ulcer on the leg, is so deeply tied into systemic health, the heart disease, the diabetes, the smoking. It really hammers home the need to look at the whole patient.
Absolutely. Understanding that connection and knowing the specific diagnostic pointers and management pathways outlined in these notes, that's really key.
Well, we really hope this deep dive into your notes helps you feel more confident and prepared.
And just as a final pointer, for more resources to help with revision like this, you can check out passthemssray.com and also freemsray.com.
Great stuff. Thanks for joining us for this deep dive. Until next time.